Welcome back. It's still Tuesday the 15th of February. I did think about putting this on the end of the last video, but I thought I'd do it separately as it goes on for too long, or I go on for too long sometimes. Now, I don't particularly like it when we get law and healthcare mixed up, but it is interesting to see this from the office of the Oklahoma Attorney General. Now, I don't pretend to be familiar with this because we don't have Attorney Generals in the UK as far as I'm aware, but I'm not really up on all this sort of thing. But there seems to be some sort of proclamation here. Attorney General John O'Connor assures Oklahoma physicians are not prohibited from prescribing off-label medicines to fight COVID-19. Now, let's have a look at what this Attorney General has said. So I was going to do it then, but we're doing it in a separate one now. So it seems to be pretty useful clarification, actually. The Attorney General's office find no legal basis for a state medical licensure board to discipline a licensed physician for exercising sound judgment. So this is good because it looks like individual physicians are going to be allowed to exercise sound judgment. Now, to me, the whole point about individualised care is that all care should be individualised and holistic. So we've always taught to assess the patient's needs, plan what you're going to do about it, carry out the implementation, whatever that is, whether it's giving a pill or giving a patient a bath or whatever it happens to be, and then evaluating the effectiveness of that intervention. So we assess, plan, we implement, and we evaluate. But the whole point is this has to be on an individualised basis. It's not a one-size-fits-all. Medicine, nursing should be individualised. And that inevitably involves judgment. And it also seems to me that this is consistent with basically, I think, the person we can call the founding father of modern evidence-based medicine, David Sackett. And he says basically that evidence-based medicine, well, firstly, medicine should be based on evidence, not on tradition. That's why we don't do bloodletting anymore. We need we do for some things, but not routinely. It needs to be based on evidence, and it had three components. One is, what does the research say? Second is, what's expert opinion? And the third is, what will the patients accept, and what do the patients want, and what do the patients tolerate? So if you go to your doctor, by definition, you're looking for expert opinion, aren't you? That's the whole point. You know, if you want medical advice, you don't go to a bricklayer. But if you want a wall laid, you do go to a bricklayer. If you want medical advice, you don't go to a plumber. Heck, you don't even go to a journalist. You go to a doctor. And I've got a GP I can use. Difficult to get hold of sometimes, but I've also got an excellent nurse practitioner. I will go to them for my medical advice, not to anyone else. So it just seems to be. This seems to be fairly obvious to me. So that's what's being said here. And again, these are direct quotes from the paper. Safely prescribing an FDA-approved drug. So things like Ivermectin and hydroxychloroquine are FDA-approved. I mean, we've been using chloroquine-based drugs for years, as long as I can remember. Many, many years we've been using chloroquine-based drugs. So another complete fundamental tenet of safe practice is that you give the right drug. You give the right drug of the right dose. Well, so let me start again. You give the right dose of the right drug to the right patient at the right time via the right route. The 5 rights. So, unfortunately, some people have taken the wrong dose of some medicines. But doctors, of course, this is exactly what they do. They know exactly what dose to give because it's all written down in their books, and they just, in fact, these days, just click computers and it normally gets it right. It prescribes the right dose. But the doctors know how to prescribe the right dose. The nurse practitioners know how to prescribe the right dose. So you get the right dose of the drug. So the right dose of the right drug to the right patient at the right time via the correct route. And nurses and doctors know how to do that. And those that can prescribe know how to do that. They know so they can give the drug safely, the right dose. And as well as that, if it's being officially prescribed by a physician, it'll be a registered human pharmaceutical. This is a much, much safer way to give any medication. Of course, it isn't. In fact, you take. I don't prescribe here. You always only take a drug if prescribed to you by your own personal prescriber, and he'll know those things. He'll know the right dose of the right drug. So that's good. And the other thing is this seems to be allowing individual medical discretion. Doctors are allowed to individualize the care. We can argue whether about the data, but it does seem consistent with the patient expectations, what many patients want, and we go to experts. At least two tenets there of evidence-based medicine. Attorney General John Connor, I stand behind doctors who believe it is in their patients' best interest to receive ivermectin and hydroxychloroquine. So if the doctors believe it's in their best interests, he's happy for that. And of course, that's what doctors are for. Our healthcare professionals should have every tool available to combat COVID-19. This is certainly self-evidently true, isn't it? Public safety demands this, according to Mr. O'Connor. Physicians who prescribe medications and follow the law should not fear disciplinary action for prescribing such drugs. So this seems to be clarification of this. You see, lawyers are good at... what lawyers do is they practice law. So you wouldn't expect them to be medical experts. What doctors do is they practice medicine, so you wouldn't expect them to be necessarily legal experts, although obviously you need to know a certain amount. You know, we need to go to people with the expertise in their field. If you wanted to fly from New York to London, for example, you would expect the airliner to be piloted by a highly qualified pilot, not by me, because I have no expertise in that field. Doctors do have expertise in prescribing. It's what they do. The Attorney General's office neither condones nor condemns a specific course of treatment for COVID-19. Of course not. They're lawyers. Why would they? You wouldn't go to a doctor if your pipes were blocked. You'd go to a plumber. Our office maintains that proper healthcare decisions are to be made between a patient and his or her physicians. It's kind of hard to argue with that, really, isn't it? I mean, that's, you know, it just seems a fundamentally true statement. And the government should not interfere with their relationship. Now, that was from the Attorney General there. Now, the FDA position seems to be unchanged. Now, this is live from the FDA website now, so we can only assume this is up to date. So it's helpful that the FDA remind us what horses look like here. So we have a picture of a horse, and as we pointed out before, the horse is the one with a long face. And presumably this is a vet, is the one that's got a human face, because she's human, obviously. But it's still basically saying that why you should not use ivermectin to treat or prevent COVID-19. So the FDA are still advising against ivermectin. And this doesn't really seem to have changed, really. The FDA has not authorised or approved ivermectin for use in preventing or treatment COVID-19 in humans or animals. But this position does seem to say that doctors can now be, at least in Oklahoma, can use their discretion. But important to note, the FDA guidance has not changed. This is not a national change in guidance. This seems to be localised permission. And this is what happened, as I understand it, in Japan, that doctors are allowed to prescribe ivermectin. It's not part of the Japanese protocol. So it's surprising how many people seem to deliberately misunderstand this. I reported on this a few months ago, that doctors in Japan, as I reported at the time, it may have changed now, but as far as I understand, is doctors in Japan are allowed to prescribe ivermectin for their patients. And I got this torrent of abuse saying ivermectin is not officially recommended in Japan. Why are you saying this? Well, I didn't say it was officially recommended in Japan. I said doctors were allowed to prescribe it in Japan. Why people are so ready to misunderstand this is rather bizarre. So anyway, that's the FDA position. It's unchanged. But the Oklahoma position has now been clarified, and always good to have clarification. And it usually seems good to allow doctors to practice what do doctors do? Medicine. That's it. Okay, good. Now, just to finish today, I've got Zita Taylor sent me a message, an email. Now, Zita's been a registered nurse for 30 years. And her son's just turned 12, so she decided, in negotiation with her son, to get him vaccinated over COVID-19. After some consideration, I decided to take him to a large vaccine centre in Manchester yesterday. Fair enough. We checked in, passed the screening questions, and then I asked if the needle could be aspirated before the injection was given. Sounds a perfectly reasonable request to me, Zita. I made the same request when I was vaccinated, completely reasonable. The person who vaccinated me didn't seem to have the knowledge of aspirating, but perfectly reasonable request to make. A heck of a nice bloke, but didn't seem to want to, didn't aspirate. Although he was quite polite about it and kind about it. We did have a discussion about it. But Zita, disappointing. The response you got was shocking. I was told very rudely, no nurse. No, I was told very rudely, no. And apparently this was by the nurse and the clinical lead, the person in charge of it. They said you don't need to do it, which we could argue about. They said it's not recommended, which is, we're told it's not necessary in the guidelines. But you'll put air in and that's bad. For a clinician to say that, if a clinician is going to be putting air in when they do an injection, they should be nowhere near a needle and syringe, nowhere near, because it would be tremendous incompetence to put air in. How do you put, it's really quite hard to put air in. So if you've got air in a syringe like that, then what I do is I flick it like that, pull it down to make sure there's no fluid in there. Then you aspirate that up, you just push that up like that, and you just get the hang of it and you know exactly how much to put in, and there you go. There's now no air in that system. So for a clinician who doesn't know how to do that, then let me tell you, you should not be a clinician before you can do that, as I've just demonstrated there. So are they admitting that they're massively incompetent? Because if they aspirated, they would put air in. Or are they deliberately lying? Or what's going on here? I used to have a multiple choice question that I gave to all my student nurses. A patient asked you a question about their condition and you don't know the answer. Would you, I can't remember it exactly, but something like A, make something up and hope it satisfies the patient and shuts them up? B, tell them you haven't got a clue and stop asking so many questions? C, say, that's a very good question. I don't know the answer to that myself, but I'll go and find out someone who does and we'll get the answer to you. All words to that effect. So what people often do when they're asked a question, they see it as a personal threat and they don't know the answer to it, so they make something up. And what they make up is very often mumbo jumbo, as in this case. How do you put air in when you aspirate? That's just ridiculous. I've been giving and teaching vaccination, all sorts of injections for 40 years, and I've never injected any air. Okay, you might inject a tiny bubble sometimes in complicated systems, but we have a zero tolerance policy for injecting air in any injections. We simply don't inject air. And if you don't know how to eliminate that possibility, you should not be a clinician. So I suspect what's happened here is they don't know. They're just following procedure blindly and they don't understand it, and they've made something up that's wrong. And if you're a professional healthcare, let me tell you something very clearly. There is no place for bluffing, and there's no case for giving patients the inaccurate information because you're bluffing and making something up. Completely unacceptable on so many levels. It's not recommended. Something bad might happen. Let me think. If you aspirate, what bad might happen? Let me just have a think. Anything bad might happen? I can't think of anything offhand. Something bad might happen. Well, what? Complications to clinical procedures are well understood, well rehearsed, memorised. So if you go in for a particular type of surgery, the surgeon will say, well, we're going to do this particular sort of surgery. The complications here are infection. The complications here are hemorrhage. The complications here are post-operative pain. The complications here are you might have poor bowel function for a few days, difficulty weeing, whatever it is. You know, these things are well known. The idea that you say something bad might happen is just not acceptable. It needs to be specified, because that's the whole point of going to a healthcare provider. You're going to an expert, aren't you? Anyway, Zita says, I was trained to always aspirate an intramuscular injection to ensure the drug was injected into the muscle, as indeed was I, as indeed I have taught for 40 years. So, can only sympathise with you and your son, Zita. I know you took your son away, you didn't have him vaccinated, but you did manage to get another centre where they did aspirate to ensure that there was no inadvertent intravascular administration. So, just a pity that healthcare providers are feeling threatened by these innocent, perfectly legitimate questions and are making up gobbledygook, presumably. Or one possible explanation is to cover their lack of understanding. If you're a healthcare provider, you must be honest with your patient. If we haven't got honesty, we haven't got trust. We have to be completely honest with our patients. Okay, so there you go. So if you're in Oklahoma, you can negotiate with your physician, and if he decides it's in your best interest, he can prescribe ivermectin for you. If you're in England, it's difficult to get aspiration, although I still think it's the best thing to do, as indeed do many others. Pity policy hasn't changed. As you know, I got a letter back from Nadeem Zahawi saying we don't need to do this when he was vaccine minister. Of course, he's moved on. I think he's somewhere else now. Politicians tend not to stay in one post for too long. Yeah, anyway, won't get on to politics. We won't start on that. Thank you for watching this update anyway.